Managing anticoagulation for a mechanical prosthetic valve during pregnancy is one of the most complex scenarios in cardio-obstetrics. The primary challenge is balancing the maternal risk of valve thrombosis and systemic embolism against the fetal risk of embryopathy and hemorrhage. Vitamin K antagonists like warfarin are the most effective agents for preventing maternal mechanical prosthetic valve thrombosis. However, they cross the placenta and can cause warfarin embryopathy, especially between 6 to 12 weeks, and fetal intracranial hemorrhage. Low molecular weight heparin and unfractionated heparin, these do not cross the placenta and are safe for the fetus. However, they are associated with a higher risk of maternal valve thrombosis compared to vitamin K antagonists, particularly if monitoring is not stringent. In the first trimester, strategy often depends on the daily dose of warfarin required to maintain a therapeutic INR. Low dose warfarin, 5 mg or less per day. Many guidelines suggest continuing warfarin through the first trimester as the risk of embryopathy is low, less than 3% at these doses, and maternal protection is superior. High dose warfarin, more than 5 mg per day, there is a higher risk of embryopathy. Options include 1. Continuing warfarin after informed consent regarding fetal risks. 2. Switching to dose-adjusted low molecular weight heparin twice daily or unfractionated heparin between weeks 6 and 12, then reverting to warfarin. Second and third trimesters until week 36. Vitamin K antagonists are generally recommended for all patients during this period. They provide the most stable anticoagulation, and the fetal risk, other than minor bleeding, is significantly lower after the first trimester organogenesis is complete. Delivery, week 36 onwards. Patients should be switched from vitamin K antagonists to low molecular weight heparin or continuous intravenous unfractionated heparin around week 36. Vitamin K antagonists must be stopped well before delivery to allow fetal clotting factors to normalize, reducing the risk of fetal intracranial hemorrhage during vaginal birth. Unfractionated heparin is typically stopped 4 to 6 hours before expected delivery and restarted 4 to 6 hours after, provided there are no bleeding complications. For warfarin, maintain the INR within the target range recommended for the specific valve type and location. Example, mitral valves generally require a higher INR than aortic valves. For low molecular weight heparin, monitoring is mandatory. Peak anti-10A levels should be checked weekly, aiming for a 0.8 to 1.2 IU per ml for most mechanical valves. Some centers also monitor trough levels, aiming for more than 0.6 IU per ml. But this monitoring may not be universally available. Direct oral anticoagulants are contraindicated in pregnancy and for mechanical valves in general. Here is a summary table of risks. If vitamin K antagonists are used during all trimesters, maternal risk for thrombosis is lowest, but fetal risk, embryopathy and bleed is highest. Next strategy is heparin or low molecular weight heparin in first trimester, vitamin K antagonists in second and third trimester. Maternal risk is moderate for thrombosis. Fetal risk is low. If heparin is used for all trimesters, maternal risk is highest, that is for thrombosis. Fetal risk is lowest. All management plans must be individualized through a heart team approach involving cardiologist, obstetrician and hematologist. Frequent monitoring is the most vital component in preventing complications. ROPAC 3, pregnancy with a prosthetic heart valve, thrombosis and bleeding. The ESC EORP Registry of Pregnancy and Cardiac Disease 3. The most recent global registry data from 613 pregnancies confirm that women with mechanical valves have significantly lower rates of uncomplicated live births, that is 54%, compared to those with biological valves, 79%. It also indicates that low molecular weight heparin based regimens are associated with higher rates of thromboembolic and hemorrhagic complications compared to vitamin K antagonist based regimens. A mitral prosthetic valve was a predictor for valve thrombosis. Benefit in terms of reduced thromboembolic events from using anti-10A level monitoring in women on low molecular weight heparin could not be confirmed or refuted as per the registry data. ROPAC was an earlier landmark analysis from the Registry of Pregnancy and Cardiac Disease that established the high risk of mechanical heart valves, noting a high incidence of maternal mortality and valve thrombosis in these patients. They concluded that women with mechanical heart valves have only a 58% chance of experiencing an uncomplicated pregnancy with a live birth. They suggested that the marked increased mortality and morbidity warrant extensive pre-pregnancy counseling and centralization of care.